The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. We are gathered here for the next episode of TMD Demystified, and I am Tony Urbanek. Today's title and topic is dental medical integration and TMD. Dental and medical integration. Now, this is the second time I've kind of taken a slice at this topic, but I want to add some additional information and talk about it a little deeper. Maybe you may not even be aware that there is a move afoot to increase, enhance, and develop dental and medical integration. That is, dental services and medical services to integrate their services for the benefit of the patient and actually the benefit of the practices. This is relatively new. The best example of this is Peter Thorne, who is the CEO of Pacific Dental Health, which it is called now. It is the second largest DSO in the country, which I believe has around 900 or 1,000 dental offices, Pacific Dental, primarily in the western half of the United States. But Peter Thorne, who is not a dentist, but started Pacific Dental with two dental practices that were owned by his father, has a movement going to integrate dentistry along with immediate care clinics, and has a growing number of physical locations where the dental office, Pacific Dental DSO office, is in the same physical office as a convenient care clinic, which I think is a wonderful idea for many reasons. The first one off the top of my head is that 70%, this is a fact, well-known fact, the 70% of patients who enter a convenient care clinic have complaints of pain or dysfunction somewhere around the head and neck, oral cavity, face, jaws, head and neck. And of course, a good percentage, of which I can't comment on what percentage of those patients that seek service at a convenient care clinic are actually more appropriately seen by the dentist. But it makes perfect sense why Stephen Thorne would want to integrate the locations of some of his dental offices with convenient care clinics, and now has named his organization, his corporation, his company, Pacific Health. Pacific Health. So kudos to Stephen Thorne, and he is not the only one who is making motion to do this. As I understand it, I did a little research that the University of Wisconsin is actually integrating programs for both the dentist and the MD physician students, dental students, medical students, so that they have portions of their clinical training together where the dentist can integrate their knowledge with the medical students, and the medical students can integrate their knowledge with the dental students, and have certain dates and times where these programs are set up for dental students and medical students to integrate, which I think is an excellent idea. while I was a senior when I was a senior medical student at Vanderbilt in the mid 70s, the dean of the medical school invited me to lecture my medical class on aspects of dentistry. Unfortunately, I only had 1 hour of time, but he offered to do it, and I certainly jumped at the chance. I don't remember exactly how I addressed it. I knew that I wasn't going to be able to do much of a job in an hour trying to enlighten my medical student colleagues, fellow medical students, on what dentistry is all about. But I did, and they appreciated it. And at least that was a good effort by the dean of the medical school, and I appreciated it sincerely. I hope some of my fellow medical students might still remember that lecture I gave them. In any case, there is a movement. There is a movement to integrate medicine and dentistry. And I think it's very, very appropriate to do this. And I want to make the case that TMD is the ideal topic, which actually makes the case for the importance of integrating dentistry and medicine. But before I do that, I want to comment on a recent article that came across my path out of Dental Economics, May of 2024, Dental Economics, just a few months ago, called Bridging the Gap. It was written by one of my oral and maxillofacial surgery colleagues out of New Jersey, Dr. Jason Auerbach. I've met Dr. Auerbach. He is the CEO and chairman of a dental service organization that I believe, I'm guessing, but probably has now 8 or 10 or a dozen oral and maxillofacial surgery practices scattered throughout mid-New Jersey and growing, where he has elected to focus not only the practices, but the integration of medicine and dentistry within the oral surgery practices. Certainly, it makes perfect sense that an oral maxillofacial surgery practice is much closer to integrating itself with our medical doctor colleagues, because roughly nowadays, 50% of the dentists going through an oral maxillofacial surgery training program finish up also with a degree in medicine, medical degree, and a internship in surgery, and then go finish up their training in the higher end of oral or maxillofacial surgery before they come out into practice or academics. But I maintained, and I make the case, that this integration should definitely not just be limited to oral and maxillofacial surgeons. It should also definitely be developed and developed significantly to include our other specialists in dentistry, and especially general dentists. I believe thoroughly that the general dentist should take his rightful place as the, quote, physician of the oral cavity and associated structures. Although he is not a maxillofacial surgeon, and doesn't maintain the surgical skills of facial reconstruction that a maxillofacial surgeon would, he is the closest thing to the patient when it comes to patients seeking advice and treatment for various kinds of pain, dysfunction, and pathology within and around the oral cavity. Now, of course, the oral cavity is just the opening and the first part of the gastrointestinal tract. It is a continuous gastrointestinal tract. And I always wondered why the dentist seemed to be given his area of expertise so totally away from and distracted from medicine, because the oral cavity, the teeth, the jaws, the periodontium, the tongue, all the tissues associated with the associated structures, salivary glands, nerves, lymphatic system, are just an integrated part of the rest of the body and the rest of the gastrointestinal system. And why it's held apart, I believe, is only historical. It is only a historical feature. You know, the medical establishment began as bloodletters in the Middle Ages, and the dental establishment began as extraction individuals, people who extract teeth in the later 14th, 15th century, associated with barber poles. Barber pole was initially a barber pole with red lines on it, indicating that there was dental services available, tooth extractions. If you needed a tooth extraction, you went to the barber pole. So, you know, and over the centuries, there was a definite distinction between the dentist and the physician, which I don't think was necessarily appropriate. And it's time to bring this back together. It's time to bring the two professions not identical and not necessarily even equal, but integrated so that the knowledge can be made useful to both, and that the knowledge available is communicated both ways, which is the second point I want to make, and that is the article written by Jason Auerbach, which I'd recommend that you read. He had 5 points on it, 5 points that he made to encourage and develop the idea of integration. First of all, attention to detail of the dentist on the patient themselves and the medical aspect of the patient sitting in his chair. Secondly, the diverse expertise and unified care that would be available if the dentist would pay particular attention to more about the patient's medical history, the patient's symptoms, the patient's comments, and that use his knowledge of the basic sciences and medicine trained in dental school to unify the patient's care, both in dentistry and in medicine, and unify it with the medical teams. The third is the innovation of the integration, and that is to be very innovative, have the opportunity to be innovative on being able to explain some of the symptoms that the medical doctors would not necessarily understand or be privy to, that we see as dentists and quite often take for granted. Fourth, developing a team effort that is not just the dentist, but the team players within the practice to be able to pay attention to their patients as they treat them, the assistants, the hygienists, as they treat them in their areas of the practice, be more attuned to the patient's medical problems, complaints, symptoms. And then fifth, being able to participate with their medical peers on an equal footing, and share information. So it's basically, without reading the article, I just gave you the nuts and bolts of it. But his article was completely designed into describing how the dentist, oral surgeon, general dentist, dental specialist can pursue communication with and for the benefit of the medical establishment, the medical doctor. I maintain that this communication line goes both ways, and it presents a tremendous opportunity for putting in the communication line, and then inviting the medical doctors that the communications line with, is giving them the opportunity to learn more about the dental aspects, quote, dental aspects, oral cavity aspects, first part of the alimentary canal aspects that we as dentists take for granted, that the physician, let's just say a PCP, I mean, if a patient comes in with a sore throat, as talked about for centuries, he looks past the mouth with a tongue blade into the back of the mouth, looking into the posterior pharynx, doesn't even have any idea what he just looked through. The classification of the jaws, whether there's any periodontal disease, if there is, what that means to the patient having chronic inflammation at the first part of his oral cavity, and the impact of that chronic inflammation on the general health and well-being, on the immune system, on the suppression of the immune system in general. And the medical doctor just looks right past that all, which is unfortunate, because he then would have an opportunity, seeing some of these things that we dentists look and take for granted and see immediately, as to referring that patient or educating that patient or helping that patient understand why it's important to treat these things that the average PCP would just look past and totally ignore and not see. So the communication would go both ways, from dentist to physician, giving them more information upon which to operate and be successful in operating as a physician on the body, and then coming the other way, giving the dentist more information about the patient in general, for the patient's benefit and the dentist's benefit. So there's this motion going on, there's this movement going on, which will end up, I believe, giving the dentist his proper position as the physician of the oral cavity. This is not going to happen overnight. I think the dental schools will need to spend considerable amount of time on their thinking process, their thought process of how they address these issues within dental school. We know that dental school is a series of technical events. From the first time you walk into the dental laboratory, the dental laboratory as a freshman, and you start, with your dentiform, working on a dentiform and mixing different dental materials, as we did. First thing we did years ago was, start mixing some plaster. How to mix plaster, but a series of technical events leading up to the fact that you're very facile at doing root canals and crown and bridge and cutting teeth and doing extractions. But that is not all there is to dentistry. And along these lines, although it may be unpopular with a lot of dentists, there is also a movement among certain states and among the dental profession and industry in general to have technical individuals who do not actually have a dental degree, a DDS or a DMD, cutting teeth and doing fillings, and having hygienists do more than just hygiene. Again, Wisconsin is a leader in this area, and I believe they have a program to do this. I just had a conversation with a hygienist who has a podcast in Canada. Her podcast, I recommend it to you. It's called Tooth or Dare, the Tooth or Dare podcast. And Canada is, if you will, light years ahead of developing programs where hygienists can go into areas and perform what we would consider in the United States strictly dental procedures. Dentists need to get away from just being a procedural doctor. Maybe not totally. There are certain procedures that are highly technical. We know what they are. I mean, a root canal is a highly technical, to do it right, to do it completely, is a highly technical procedure. A dental implant and the reconstruction on that dental implant prosthetically is a highly technical procedure. But other technical procedures in dentistry are not quite that highly technical and can be given over to people who are trained technically and don't have to spend a total of 4 years, 2 of which going through basic sciences to get a technical procedure done and completed. Now, For the purpose of this episode, I want to just repeat the title, and that is Dental Medical Integration and TMD, because TMD, because of the disparate symptoms of this problem, is an ideal mechanism or service or disease that can actually play out very well on the integration and the knowledge between dentists and physicians. For the umpteenth time, the symptoms of TMD are chronic or recurring headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, fullness in the ear, dizziness, dizziness/vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of locking of the jaw. Now, when patients have one or more of those symptoms, they may not go to the dentist. In fact, I believe more than not, they don't start at the dentist. But TMD is one of those problems that each of those symptoms is driven by chronic inflammation within the joint, created by chronic inflammation within the joint. The physicians, because of the disparate symptoms, this doesn't make any sense to them because they don't understand the temporomandibular joint. They don't understand that this joint operates like any other joint in the body. When it becomes chronically inflamed, it sends out autonomic signals to the muscles to tighten up. They don't have that knowledge. There are a growing number of dentists who have that knowledge that are affiliated with our practice and with our company that teaches it, develops it, brings on doctors who become network providers who fully understand that all of those symptoms, those disparate symptoms, can be addressed and literally conquered with a device that simply separates the back teeth long enough according to a protocol that allows the inflammation to decrease, just like non-steroidal anti-inflammatories allow chronic inflammation to decrease in the body, specifically a joint, any joint, knee, hip, elbow, or TMJ. And this kind of thing, that is TMD, lends itself perfectly to the integration of medicine and dentistry. Stephen Thorne is right on about putting a walk-in clinic and a dental office right next to one another, or even in the exact same space, because these symptoms are so common. Headaches, better known as anybody with a bad headache now has a migraine headache, and we know that the science on migraines can't explain what causes migraines, but we know that bad headaches, recurrent bad headaches, are associated with inflammation of the temporomandibular joint, causing the muscles to get tight on the muscles of mastication, and patients will complain of various pains throughout the face. They end up in a walk-in clinic because of various pains around the face, oral cavity, and neck. And the physician's assistant or nurse practitioner in the convenient care clinic has no idea what's going on. None. And then sends the patient out at best with something that may treat pain, a narcotic, or they refer out for MRIs looking for brain tumors, or various other misleading treatments that aren't going to get the job done if the symptoms are actually generated by the temporomandibular joint. This is extremely common. Meniere's disease, same thing. Patients have ringing, fullness, dizziness. They either go to their PCP or the PCP refers them to an ENT, at which point the workup is done. It is confirmed that you have tinnitus, subjective hearing loss, and/or vertigo. You're told you have Meniere's disease, and they have no solution for Meniere's disease. But if you have TMD and inflammation in the joint, and the inflammation goes down, the symptoms diminish of tinnitus, subjective hearing loss, and vertigo. So TMD is the poster disease that lends itself perfectly to the integration of medicine and dentistry, just as one of many examples. It's not the only one, but it is just in your face. And once it's understood and the medical doctors have an understanding that, oh, this patient doesn't have migraine headaches, this patient doesn't need a $2,000 or $3,000 MRI, this patient doesn't need to be put on neuroleptics because of chronic facial trigeminal neuralgia, which is just a catch-all phrase that the physicians use constantly when they hear about a unresolved facial pain of some kind. They just call it trigeminal neuralgia, which is basically a meaningless group of words, which literally means pain associated with the trigeminal nerve. So what? Doesn't say anything. But that's where the state of the art within medicine is. Medical doctors don't know what to do about it. They don't know what to call it. They just call it trigeminal neuralgia and throw something at the wall to see if it sticks. So there's an opportunity here. It's an opportunity for those interested in treating TMD and actually treating it successfully to enhance, to move forward this concept of integration of dentistry and medicine. If you learn how to treat TMD, you have an open communication line to all of your physicians in your community because they want to know. I can promise you the physicians, they want to understand why a certain percentage of patients come in with these disparate symptoms that they can't explain. Makes no sense to them. Brings up a point I had. I just had a patient like yesterday, had the symptoms, typical TMD symptoms for many, many years, but she finally presented to my office and was referred to my office, and the chief and the event that's tipped the symptom list over in favor of an immediate consult is the patient felt she was having a heart attack because her left arm was starting to get numb and tingly and had a certain amount of pain associated with her shoulder pain. She ended up in the emergency department, in the emergency room. And of course, that was a $2,000 workup to prove that she didn't have a heart attack, and actually left the emergency department with just everybody shaking their head. We don't know what this is, but because of the other associated pains that she had been having, which were earache and jaw pain, ended up at her dentist, and the dentist identified the TMD problem and referred the patient in. But the patient was very upset because she ended up at the emergency department thinking that she was having a heart attack because of the shoulder pain and the arm, hand, finger tingling and numbness, which are well-accepted symptoms of TMD and explained well that I've done in many other episodes. All right, well, I'm making the case. I'm making the case for the dentist to take his position. It's going to take a little time, but you can do that without waiting for the dental schools to set you up to do this. In fact, I wouldn't wait for the dental schools to do it. It may take a while. They're slow to move, and they have a lot of things that they need to teach. However, being aggressive and taking control and learning how to treat TMD, then you will have the ability to communicate with all of the physicians in your community, educate them the way we do out of our practice here in Middle Tennessee, educate them as to how to identify and make the distinction between headaches of TMD origin and any other kind of headache, or neck pain associated with TMD, rather than going through a long litany of x-rays to determine that there's no problem with the C-spine and that the problem with the pain in the neck is coming from the temporomandibular joint. All of this is available. It's easy really to educate our medical colleagues. They appreciate it. And in turn, then they send you huge numbers of TMD patients to treat. And also you're number one on the list whenever they think of somebody that needs dental treatment, true dental tooth treatment. You're first on the list in their mind because this dentist has an interest in patient care, has an interest in educating his medical colleagues, and the communication begins to go both ways. And it's a win for everybody. It's a win for you as an individual, as a doctor of dentistry. It's a win for the doctor of medicine, for the specialties in medicine, for the convenient care clinics, for the neurologist. It's a win for the patient, particularly for the patient. They are no longer run around in circles about these disparate symptoms. And in this practice, what I've observed over treating well over 5,000 people within the past 10 years successfully with this problem, most of the patients that hit our office, hit our practice, hit our clinic have been run around in circles for considerable time. We're not talking days, we're not talking months, for years. They have been run around in circles by both the dental and medical establishment because the two establishments have not been integrated. Because the two professions between the medical doctors and the dental doctors have not integrated their knowledge and their communication. It's time for us to do this. It's time for us to follow the lead of Stephen Thorne in Pacific Dental Health, Pacific Health, and take that lead and develop it in your community, and then it'll be integrated in your community and the next community. And sooner or later, the dental schools won't have to be told what to do. They'll jump at the chance to fulfill the need to have the physician, the dentist, as the physician of the oral cavity and related structures. I appreciate your attention. I appreciate you following this along. If you have any questions, I'm available to communicate with at tony@tmjservices.net. If you would like to learn more about the device that actually has solved the TMD conundrum, the TMD dilemma, which we had to name the Urbanek device and protocol because patients wanted to name it Miracle Device, Save My Life Device. I refused to do that. But if you want to learn more about it, the website is www.urbanektmj.com. Until next time, I will look forward to coming up with the next topic that hopefully will stimulate your thought process, help you in your practice, help you treating patients. I am Tony Urbanek, and this is TMD Demystified.